Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on consent. I hope you enjoy it.
Hello and welcome to this Reducing Risk podcast for Medical Protection. This is another in our series on consent, and today I'm here with my colleagues Sam King and Tim Cookson, and they're joining me, Lucy Gibbard, for today's session. And today we're talking about consent. How detailed and how specific do you need to be? It's really common that patients complain that they weren't appropriately consented when they become unhappy about the outcome of a treatment or procedure. And so it's really important that we actually look at how detailed we need to be in that process and in what's documented. So today we're talking about how specific you need to be and how to use the consent as a process to your advantage. So we'll start with a case that illustrates a few of the problems. This is a made-up case, but it's based on some facts taken from a real one. So the patient, Mrs. B, was seen in outpatients by a locum surgeon regarding her rectal bleeding. In the clinic, she signed a written consent for her hemorrhoids to be surgically excised, i.e. she was going to have a hemorrhoidectomy. At that time, the notes documented that she had prolapsing hemorrhoids, and the locum explained the procedure for a hemorrhoidectomy and put her on the waiting list. The consent form had a pre-formatted area in it, so that although the locum just used the word hemorrhoidectomy, there was actually a typed sentence underneath which added and or further procedures or measures that my surgeon considers necessary and essential during the procedure. And I think we'll talk about that later. The form notes that the consent was valid for 6 months from signing. And look, the locum can't remember later on exactly what he told the patient about the procedure, but he thinks he gave his standard advice about possible complications and the chance of recurrence. So the initial surgery was planned for Mrs. B 4 months after their outpatient appointment, but unfortunately it was cancelled because of staff shortages, not an uncommon scenario. She was then rescheduled onto another surgeon's list at 2 weeks' notice. Because the surgery was considered to be straightforward, the new surgeon didn't insist on seeing her prior to surgery. So the first time he met her was on the day of surgery. On the day of surgery, the surgeon recollects that he talked through the procedure and thinks that he mentioned the possibility of banding as an alternative treatment at the time. But the patient later didn't remember that banding was ever mentioned. However, that surgery ended up being cancelled as well, as the previous patients on the list had taken longer than expected. So this patient was again rescheduled, so we're at the third time of scheduling, and again she was last on the list, which was again running late due to acute surgeries taking precedence. The surgeon recalls speaking to the patient before the surgery, but the conversation wasn't recorded, as so often is with any conversations in the pre-op area, and the patient doesn't remember the conversation at all. The surgeon thought the patient was aware of the possibility of banding, and the patient thought she was having a hemorrhoidectomy. After she'd been anaesthetised, the surgeon examined her and found that she actually didn't have resectable hemorrhoids, and he didn't feel it would be safe to proceed with a hemorrhoidectomy. So instead, he banded her internal hemorrhoids. This later went on to having pain and bleeding, and the patient made a complaint to the HDC. The HDC expert confirmed that the surgeon had performed the appropriate surgery for the clinical situation that he found. But the doctor was criticised for not specifically consenting Mrs. B for the procedure that she had, which was banding, especially as there was a slightly increased risk of recurrence of her hemorrhoids with this procedure. There was also a criticism that there was no record of any of the conversation the surgeon had had in the pre-op area of the patient on the days of her surgery was scheduled. The HDC commented in their advice that they expected hospitals to have robust systems to record all the communications that are had with the patient and what the patient has been told in the course of the consent process. In this case, the surgeon wasn't found to be in breach of the Code of Rights, but there are a number of issues that were raised, which I thought might be helpful to discuss. So, Sam, how much detail do you think we do need to go into when we're describing a surgical procedure to a patient?
That's a really good question that commonly comes up, of course, in our cases. There is a medical council statement on this, which says you must give your patient the information they need to help them make a fully informed decision. Share information that is relevant to them in a way that they can understand, and allow reasonable time for the patient to make their decision. Think about whether there is anything else you can do to make it easier for your patient to consider the different options and make a fully informed decision. Cover the options available, including those that you may not be able to provide yourself. So it's pretty robust, our requirement from the Medical Council there.
But it's also pretty broad and not at all specific, really, is it? So how do we actually know how much detail we need to go into for any particular case?
So we've looked at the Medical Council statement, and we can also actually look at the Code of the Health and Disability Services Consumer Rights, which gives us a little bit more information on this in Right 6, which says every consumer has the right to the information that a reasonable consumer in that consumer's circumstances would expect to receive. So the test there is a reasonable consumer test. But again, we get left with it's quite hard to know what a reasonable consumer wants to know.
And not only that, but many of our patients aren't necessarily reasonable. The Medical Council does add a little bit more by saying that you need to highlight the risks specific to your patient and give your patient pamphlets, brochures, or website links that provide more information about their condition.
Yeah, look, I think giving leaflets is very useful. They often lay out possible complications in quite a lot of detail. One of our problems, though, that we often come across in our cases is that we fail to write down what leaflets we gave to the patients, so that later on when there's a problem, there isn't actually any evidence to show what leaflets they were given and therefore what complications they were warned about.
And another consideration really is, what do you need to tell the patient in terms of both the magnitude and also the consequences of a particular risk? So, for example, you may not need to explain a risk that's pretty uncommon, but the outcome of which is pretty minor. But you may be expected to tell a patient about a risk that is uncommon but serious. So, for example, I've been assisting a doctor who inserted an intrauterine device but did not advise the patient beforehand of the risk of perforation. So the risk of perforation is quoted as being only 1 in 1,000, so it's really uncommon, but it's pretty significant if it happens. And of course, what happened was that this patient did suffer a perforation, and lack of information about this risk was a key part of the complaint that she lodged.
I think that the more or the greater the potential for difficulty with complications post-op, the more you need to inform them of. And something that's very topical, it's been in the media quite a lot, is mesh surgery. And a number of those cases have just gone through the HDC, and it's been clear that the commissioner has quite a high requirement for the information that you provide, and making sure that patients are given as much information as possible so that they can make an informed decision. Now, for the proceduralists who are listening, most of the operations that you will be involved in are probably fairly stock standard and nothing controversial, if you like, about it, or nothing where there's a high risk of complications. But the higher the risk of complication, the better you need to be in terms of your process with consent.
So, look, how do we record what information the patient's being given? Because all too often clinicians remember discussing things with the patient or know that it's their normal practice to do that. But recording it is often a bit of the problem.
Yep, and saying something like, my usual practice is to warn patients about the possibility of X, Y, and Z occurring, actually is never as powerful as being able to say, I have documented that I informed my patient that X, Y, and Z were potential risks of this procedure. So the documentation is the key bit.
I think having a checklist for yourself just to make sure that you have covered every aspect of it is an important thing, and it's just helps you as an aid memoir and a prompter to make sure that you've done that, and you can put something down. I mean, if you routinely ask people to watch a video about the particular procedure, as some clinics do, then you can say that, refer to video tick, and that might be a simple way to get your documentation complete.
Yeah, and I think that's that whole thing about writing down a whole conversation often is very time consuming, and it's not actually very realistic in an outpatient clinic or in a clinic to actually write down exactly everything you've said. So actually having something in writing that you give to the patient can be very useful. And as we said, if you're going to use pamphlets, and there are some really good pamphlets out there. Some of the colleges have got great pamphlets that are used very routinely, but you just need to make sure that you've recorded exactly which pamphlet has been given to which patient.
Yeah, and it's often that little step of recording that the pamphlet has been given that is the problem. And we've actually got a case at the moment where the hospital has said that they routinely give a pamphlet on the surgery that was about to be undertaken, but the particular patient said that she was never given it. And the problem was that there was no documentation in the notes of her having received that particular pamphlet. So Sam's idea of having a checklist that would have a little tick box beside that is certainly relevant. However, it's really important to remember that just giving a leaflet and asking the patient, for example, to contact you if they have any questions is not sufficient for informed consent. The relevant information must be discussed in addition to any written material that's provided. And then, for example, the notes could just record something along the lines of risks discussed as per pamphlet provided to patient. And you might add opportunity for questions and then end it at that. And that kind of summarizes the whole thing without having to lay out all of the details about every single thing, because you can just go back to the pamphlet. You've got documentation that they had received the pamphlet and that it was discussed.
Many of our members would dictate a really thorough letter to the GP, which would include the risks and benefits discussed and the consent process that has taken place. And if doctors routinely copy the patient into those discharge or clinic letters, I think that helps to prompt the patient to remember, oh, that's right, that is what we talked about. I mean, let's face it, most patients probably only remember a very small proportion of what you discuss anyway. And so any written material or reminders of, yes, this is what we went through would be helpful.
Yeah, I've also noticed that some plastic surgeons who use a reasonably brief standard consent form also get the patients to sign an agreement to treat form, which is several pages long and lays out in detail, every possible adverse event, and tries to ensure that the patient has got reasonable expectations for what the surgery can actually achieve. So I don't know if that's probably suitable for all surgeries, but actually having a document that's given alongside the consent form, which has got all that information in it, can be maybe a useful idea.
Yeah, well, it certainly can't help to provide that. And I would say in that particular case for surgeons who are doing cosmetic procedures, it's really important that the patient doesn't have unrealistic expectations of what the outcome is going to be. So if you've got a document that covers all of those things, that's going to be useful. I guess it could still be argued by the patient, well, the doctor didn't go through that whole document with me, so I didn't fully understand. So again, just the provision of the information in written form, the messages, it's not sufficient for it to be fully informed consent.
But it helps.
But it certainly helps.
It helps.
And the lack of it,
it definitely doesn't help.
Yeah.
And actually, the one I saw, they had actually initialed each paragraph, so that they clearly had gone through it with the patient because they were initialing it. So
I think videos are actually quite a good way to do it if the clinician videos themselves speaking to the patient, because they're going to, obviously use their regular language, and they've obviously already built up a relationship with the patient, so they're more likely to understand what's in there, as opposed to necessarily a pamphlet where patients might have difficulty understanding the language used. So I think videos are a really good way to go.
Yeah, and then that kind of leads us on to another issue, is about who does the consent, because the college statement does actually say that you can consider delegating some parts of the informed consent process to others. So having a video is a way of delegating a part of that process, as long as it's only part of it, as I'm sure Tim will be saying. But it does highlight the question of who could do the consent. In this particular case that we discussed at the beginning, the consent was done by a locum, which really isn't uncommon. I think, in fact, it's probably very common that it's a different doctor in outpatients writing the consent form from the person who's doing the procedure.
Yep, the house surgeon who plugged the person in may be the person who's doing the consent. And look, although, yes, you can delegate bits of the consent procedure, ultimately it's the person who's providing the treatment who's going to be held responsible for ensuring that fully informed consent has been obtained. And you can't kind of delegate that ultimate responsibility.
I think in some of the cases that I've had as well, excuse me, part of the difficulty has been various clinicians, whether they be nurses, junior doctors, senior doctors, have been part of that consent process. There needs to be some central way of documenting that so that everyone gets to see that process and ensure that nothing is missed. And because if something changes along the way, the patient decides, oh no, I don't want that part of the procedure anymore, I want it to be done this way. If that's not recorded, the actual operating surgeon may not know, and we've certainly had cases where the patients have complained following that. So how do you document it and where do you locate it in one place is actually very important.
Yeah, I think I've had a similar case to that, where there was a specific wish of the patient documented in the notes but not on the consent form, and I think on the day of surgery they didn't actually look back in the outpatient notes, and so actually it was missed. So the issue of who can do consents, we had a call where one of our members asked us whether or not nurses could do the consent process and the pre-admission for routine screening colonoscopies. And I don't think there's any doubt that nurses can provide patients with information, and they're often in a very good position to explain what the procedure involves and to talk through the procedure with the patient. But as Tim says, it's important that having done that, it's actually the person who performs the procedure is actually responsible to make sure that's happened. And also you do have to make sure that you're making your consent specific to that patient, that it's not just a routine thing for everybody, and that if you've got a patient with specific underlying health conditions or who's on a blood thinner, for example, actually the risk for that patient may be different from every other patient. So you've got to be careful not to standardize your procedure too much, and to delegate into kind of a factory system too much. You actually need to make sure you're actually looking at the patient in front and making sure that they are actually the person that you're consenting, and that the risks for them are being considered.
And that's certainly a potential problem when you've got a relatively junior doctor who's doing the consent, because they may not fully understand the patient's individual circumstances, but they also may not have a full understanding of what the procedure involves, and be fully informed themselves of what the risks and benefits are. And I remember being very uncomfortable as a house surgeon, doing consent and explaining to people what the problems might be of an operation that I'd never seen in my life and had no idea what it was. And I'm sure you two have shared similar experience.
Yeah, but look, you need to be clear that it's not. You don't have to be able to actually be competent to perform the procedure yourself. So the junior doctor can go through the consent process if they understand what the procedure is. They don't actually have to be able to do it themselves.
Yep. And so the medical council statement also says that informed consent is an interactive process between the clinician, the patient, and sometimes those close to the patient, such as their family or whānau. And it's not a kind of a one-off. Consent may be actually the result of 3 or 4 discussions about the process. So it doesn't have to be a single meeting all done and dusted. It's an interactive process, and that may go on for a little time.
For complicated operations or complex patients, it's much better that it isn't just a one-off, isn't it? It's much better to have a conversation over a period of time, so that by the time the operation comes up, the patient feels fully in control, knows what's going to happen, and has provided proper consent to it.
Yeah, I thought it was quite interesting that the medical council statement says that the informed consent is a process between the doctor the patient and their family. Whereas actually, I think in real life, it's actually not just the doctor. It often is the pre-admission nurse and the house surgeon and the anaesthetist and sometimes others. So the medical council statement doesn't really reflect actually what happens. It's not just the doctor.
True.
It is a team. It's a team effort.
I think the HDC understand the process that happens, particularly in hospitals, that a number of clinicians are involved, and they don't have any problem with delegation of parts of the consent process. The difficulty is always, unfortunately, going to be on the surgeon who does the procedure, who often has never met the patient before, and that's the difficulty for that particular surgeon.
Mm. So what do you think about consent for specific parts of procedures? Because often there are parts of procedures that doctors may consider very routine, like the fact that you're going to be inserting a urethral catheter, that comes as a shock to the patients later, and they complain that they weren't consented for it. So, what do you think? Do you have to consent for every little additional thing, like putting a catheter in, if you're going to put a catheter in when the patient's asleep?
I think it's less so much, if you like, about consent, but more about informing the patient what's going to happen, how the surgery is going to run, what sort of level of pain they're going to be in, are they going to have, pain pump or whatever that happens to be, so that the patients have a sense of control. I think that often it's the patients who feel like, I was completely out of control, I didn't know what was happening to me, they're the ones who are more likely to be unhappy and want to complain. So I think it's reasonable to just explain to the patient the process that's going to unfold.
Yeah, and if you woke up with a catheter, urinary catheter, never having been explained that that was going to be part of the procedure, I think you'd be a little surprised, really, to have that extra addition to your system. I mean, you might usually be warned that there might be drains and drips and all those other things going on, but yep.
And maybe that's where a video or some pamphlets can come in really handy. I don't think you have to specifically say, consent them for a catheter, but at least it will inform them without you having to go through the process in detail.
Yeah, I think it is important that you've got to go back to that reasonable consumer test. And I do think that most reasonable consumers would want to know if they were going to be catheterized.
Yep.
I think that's reasonable. So I think that actually in general you would want to consent to that.
And you raised a good point earlier that so many things become routine for clinicians that we don't even think about it. Like, what's the big deal? You have a catheter. But for patients, often it's new, it's scary to be in a hospital, and they have no idea how it's going to turn out. And so if you put yourself in their shoes, that might help clinicians to think, okay, this is what I need to put in place so that they are informed about what's going to happen.
And the other thing we've talked about is that the consent needs to be very specific to the circumstances of that particular individual, not the blanket kind of process. So, for example, the statistics for the ultimate outcome for a 90-year-old who's got a fractured neck of femur repair are going to be very different from that of a 70-year-old, and they need to be aware of what they can reasonably expect as a result of the surgery.
I thought it was actually very interesting, the consent form in this particular case, which stated that we can any other thing that
thing we'd like to do, yes. Any other further procedures or measures my surgeon is necessary and essential during the procedure.
I'm not sure that the HDC would approve of that kind of statement.
I don't think that's valid.
In fact, I think we've had specific comment from the HDC that they regard that as not being reasonable.
I think that's not a helpful. It looks like it would be very helpful, doesn't it? Because it looks like it kind of gives you blanket consent, but it doesn't. No, it's probably just false reassurance, isn't it? So do we need to tell the patient who's doing the procedure?
I think ultimately yes. And there's been some media articles about medical students and consent, for them to be doing examinations and procedures in theatre. And it's as part of the Code of Consumer Rights, patients have a right to know who is doing the procedure and their qualifications and experience in doing that procedure. And when you're in private, I think that's a little easier because it's going to be someone who's an SMO level, but in the hospital, often it's a junior doctor, and patients do have a right to know.
So then can patients insist that they have a consultant do their procedure? Is that, if we're saying that they've got a right to know, can Mrs. B say, no, actually, I want an SMO doing my procedure? Is that, I think our health system would grind to a halt if every patient said that.
I think they can ask. It's entirely up to the hospitals as to whether or not they can provide that.
Yeah, it would certainly set a precedent that a hospital may not wish to be a precedent if people can then insist on having just a particular person. And I think many of the consent forms specifically refer to, there will be no, we're not going to name the person who's going to do your procedure, the specific person. And Tammy talked about students before, and the HDC has certainly been very interested where students have been actively involved in a procedure. And there's been a case that has been published recently last year by the HDC where a registrar arranged for a 50th med student to insert a Mirena IUCD for an intellectually disabled woman under general anaesthetic. Now, not only was no specific consent obtained for the student to do this, but actually the consent that was signed specifically stated no students. So it was even worse. In this case, it was actually the DHB that was found to have breached the code because they didn't have clear enough processes to ensure that, what was in the consent was actually known about in theatre. But the registrar was criticised but not breached for their actions.
Again, I think it's one of those things when you're in a teaching hospital, it's just routine and normal practice. And we often forget that there is a person receiving the care who, obviously has a vested interest in what happens to their body, particularly when they're under GA. So it's worth bearing in mind. And, you would expect that any particularly students would introduce themselves or they're introduced to the patient and their role.
But I think if a patient says, I'm not having the registrar, I only want a consultant to operate on me, I think it's reasonable for the team to turn around and say that surgical is a team effort. There's often a registrar there and a consultant there. They often do bits of the operation each. A consultant is not going to ever work completely alone. And actually, that's not the service that we're offering in our hospital. Therefore, this is a team activity, and you can't specifically say, no, I only want the consultant as an option anyway.
No, I would agree.
And equity is important. It's really important that actually everybody gets the same opportunity to have the same standard of care. So it doesn't seem fair that somebody could say, no, I'm only going to have the consultant, and that's the reason. The consultant should be doing the surgeries on the person who most needs that skill level.
And I think that, registrars are not going to be performing operations alone unless they are credentialed in it, unless they're competent to do so. I think that in the hospitals, that's how it works. And so I think patients can be reassured that they're getting very competent care, even if it's not the consultant.
So when we're saying that the catch-all that they had on this consent form about any further procedure or measures that my surgeon considers necessary, that we're saying that that's not really very valid, what do you do as a surgeon when actually in the middle of surgery there is a finding that wasn't expected and the patient's asleep? And it clearly needs to be dealt with, and it's the patient's best interest for that to be done. Is there anything you can do on your consent form? Is there anything you can do to actually cover those situations, those unexpected ones that you haven't anticipated?
I guess if you said to the patient, while I've opened your abdomen and I suddenly see, just by chance there's perhaps a liver lesion or a lesion on your bowel, how would you, would you consent to me taking a biopsy or whatever that is? And I think if you can...
But you've anticipated it.
Yes, you've anticipated it. But you could make that a part of every operation, as included in the consent form. The patient agrees to having a biopsy if that's found. But I think if you don't have explicit consent, you proceed at your own peril. And we've had cases of this where it seems like absolutely the right thing, and most patients would thank the surgeon, say, "Thank you for doing that. I don't need another GA." But unfortunately, there are some patients who don't like that, who won't consent to it.
And of course, it's those ones where there's no specific consent, where actually it's the extra bit that caused the complication that leads to significant distress for the patient. And they can quite rightly turn around and say, well, I never consented to that, so why did you do it? And certainly one of the early cases that we had on that scenario, the outcome was very clear, and the surgeon was breached for, I think it was doing a biopsy of a liver lesion that was an unexpected finding when he was busy doing something else in the abdomen. The solution is that you observe it, you close the patient back up again, you wake them up again. When they're in a fit state to discuss it, you then say, actually, we found something really significant and our recommendation is that we go back and deal with it, but we needed to get your consent to do it before we could go ahead.
Yes, I think that is exactly what the HTC would say. Don't do things that aren't consented for unless it's life-saving. I think if it's a life-saving situation, then I think you are allowed to proceed, but only to the limit to save the life. You're not allowed, you just do the minimal that you can possibly do in that situation if you haven't got consent. But if you have to, you have to. Okay, so what have we learned today? Sam, what do you think we've learned?
That we do need to be quite detailed about what a procedure involves and what the surgery will be, particularly if there's a chance that the clinical situation, which is found at the time of surgery, may alter exactly what procedure is done. I think we also need to be really careful in our documentation of the consent process and whether or not you've given the patients written information or asked them to watch a video. And it's always important to say exactly what documents were given, and that way, if there are concerns or complaints arising later, you can demonstrate to the medical council or HTC to what steps you've gone to inform the patient.
Yeah, consent is certainly something that the HTC takes very seriously, and lack of consent or improper consent will certainly be criticised or will be a breach finding. So, it's not something that is just an add-on. It's a critical part of the whole procedure. It can be a team effort, as we've discussed, but ultimately, the person who's doing the procedure is the one who's responsible to ensure that the patient understands and has given fully informed consent for it to go ahead.
Yeah, and the patient needs to be told who's going to be doing the procedure, especially if that person is in a training position. So I think that's very important as well.
Mm-hmm.
Okay, well, thank you for listening today. If you have any specific questions about this podcast or anything we've discussed in it, do feel free to give us a call on our advice line on 0800 22 55 677 and ask to talk to one of our advisors, or you can drop us a line at our email address, which is nzpodcasts@medicalprotection.org.
Thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review.